my daughter and my wife said, you're always talking about blood thinning, so put something red on the screen. So last night, it was actually a blank screen, so I've got blood red on there. But they were happy, so I'm happy. So my brief is not about going into atrial fibrillation, i.e. the medical side of it, but I will answer some of the questions, because I'm a GP with special interest in cardiology. I've done quite a bit of training in rhythm disorders. But it's really about what the network is doing and can do. What you've heard up to now are individual interactions. So a person comes in, a clinician does something, and there is a net result. But we have to look at population medicine. How can we actually impact a large group of people living in the community? So don't forget, hospitals are busy, practices are busy, and there is time issue everywhere. All of you guys are busy as well. So we've got to fit it all in. So, so before I start, I think anecdotes are important. And only 4 weeks ago, one of the parents from our school, he was discussing about his mum, 76-year-old lady, perfectly healthy and well, not on any medication, sat down talking with him. He went for a cup of tea to see his mum, and she said her right arm was feeling a bit numb and a bit funny, and she was just trying to shake it off. So, so he said, well, why don't, are you feeling okay? She said, oh, I'll go and have a lie down. Half an hour later, that was she couldn't speak properly. 4 hours later, they were in hospital, and 2 days later, she was dead because she had a big bleed. And these things do happen. And I think in clinical practice, we have to look at how do we actually make things better. But what was worrying was he never realized this was a stroke in the making. And I think whilst all of us are trying to do good jobs, I still think there is so much health education to be done for not just clinicians, for the population, for people to recognize early symptoms and take action. So for that reason, I just wanted to give you a visual memory jog. Think AF, you have to think stroke. So you can't really have a discussion or even think about AF without having mentioned about stroke risk before the person walks out of the room. And that happens even now, every day, simply because, as Umesh mentioned, people don't just come in for one thing, people come in with multiple things. And more people know they can have much more of interaction between clinician and the person involved, and I think healthcare only benefits from it. So I'm not going to bore you with details, but just reinforcing a couple of messages. Strokes happen for many reasons, like the gentleman behind me said. There are several reasons why stroke happens, and AF is one of those, and it does increase the risk of strokes. I think it's about 5 to 6 times that AF increases the risk. And I think it's just this line, in Lancashire County, between 1998 to 2005, there were 1,317 deaths per year for the 6-year period. And that has come down for the period of 2006 to 2013 to 950 deaths. Now, this is stroke deaths, okay, not just all deaths, stroke deaths. So yes, we are making progress, but there are lots more we can do. So from the cardiac network, what we've actually done is about, I think, middle of last year, the network was tasked with looking into why the northwest of England had a higher stroke mortality rate. That was the task given to the CCG groups, and the network was commissioned by the group of CCGs to look at the entire stroke pathway. So what they were commissioned to do was to do an end-to-end stroke review from A to Z, to including people being discharged and being well and able to look after themselves, to people dying and having the end-of-life care to be the best care that could actually be. So as part of the review, I think we've done some fabulous work. and I think that will all be presented in time to come. And I think, big thanks to all the network people who really, really work hard. So why are we doing all this? Because in our CCG areas, I think 2 of them, Blackpool and Blackburn, are unitary authorities, but all of the others are something else, don't ask me. But they're all CCG areas. And we all have our standardized mortality rates are higher. The lowest was central London, Westminster area, 60. And the highest was central Manchester, 146. But in the northwest, all the areas have higher stroke-related deaths. And this is something we have to work in terms of population medicine to bring it down. Individual care is important, but we've got to work across the board. I think this slide, has already been shown by Umesh. And I think we are starting to see improvement. Because when you look at the figures from 2012-13, the SNAP data for strokes showed only about a small minority of people with AF were anticoagulated. I think that is starting to improve, and I think what I wanted to show is a success in Blackpool. And I think Blackpool, what they did was they made pulse checks important. They incentivized and they did loads of campaigns about practices doing pulse checks, as well as planned programs for opportunistic screening. Jeannie, who will actually talk to you later, has been all over the place in rain and sunshine, feeling people's pulses and making it happen. And look at the figures. If you look at Blackpool's, the green chart, they have 64.6% anticoagulation rates, which I think is fantastic. And they are still carrying on doing the good work. And I think we all can learn from that. So I think it's about reproducing or learning from good behavior and good work that happens everywhere else. So in terms of population medicine, so me as a GP, seeing one patient is great, but ideally we've got to get everybody sorted out with the best possible medicine. So there are software tools which are available which can give us detailed list of patients who are on anticoagulants, who are not on anticoagulants. And I think when you actually start to study these sort of audit data, what comes across is the majority of AF patients are at high risk of strokes. So you've heard about the CHATS-VASc score, but just to simplify it, if you are having AF, man or woman, if you have a single risk factor or more, you are immediately at high risk. And that single risk factor could be age over 65, but any risk factor puts you in the high risk group. That means you automatically would benefit from anticoagulation. So in terms of looking at it, it's either low risk and you don't need it, and you get older and you become high risk. So GRASP data tells us that almost 80% of people are in the high risk group. But the same data set shows that almost 30% are not anticoagulated. So these are those figures from January 2015. So I've tried to look at most of the data which I could find, and they are fairly consistent. So that is the proportion of people with AF who are high risk. That means they would benefit from anticoagulation, who are still not on anticoagulants. So that is our target. We have to do something about reducing that burden. So this slide just showed the slide, so I won't really go into that. But I will just focus on the last line, because he has said about personalized package of care. That is new, is about taking time to treat the individual as a learned person and explaining to them what the issues are so they can make a judgment call based on the information you've given. That is a lengthy discussion. The problem is most of us have 10 minutes I think is about trying to marry too many things and trying to make it all happen. I think that is why education and I think events like these, which brings in so many sectors, are fantastic. Most GPs sit isolated in their practices and see patients. Most GPs aren't aware that there are so many sectors looking at problems, trying to solve problems. And I think it's very, very heartwarming to have events like these. So personalized package of care is important. And one of the issues we do see is when people come to see clinicians, we are seeing a human being with all their frailties and their vulnerabilities as well. And it's trying to see past all that and trying to make an assessment of if that person had a stroke, what would their life be like? And it's trying to make a judgment call based on the knowledge you have, based on the evidence, and each person is different. So when I did an audit on my practice data, quite a few people were sort of excluded from anticoagulants because they have fallen down. There was a history of falls. But we're trying to push this agenda that if you fall, if you are having a few falls which are just you've slumped down and you fall, they've actually recorded that a person has to fall practically every day to make it a risky sort of issue. In other words, most falls are okay as long as you take a history and you understand what the fall is like. So it's all about understanding that individual person's life. And again, you already know there are 4 agents available, and I think it is important for patients to make the choice. And I think we are all biased one way or the other. And the NHS has to be cost conscious. But in 10 or 15 years, it'll be interesting to know how we manage AF. Because if you look at the data that is available, you have loads of data coming in, but most of the data about the newer anticoagulants are fantastic data. They're all good. Warfarin and the 3 that are available, that's a 4th one coming out later this year. Even the data on that is absolutely great. They all do almost a 60 to 70% stroke risk reduction. So they are all good. However, people are different. So I have patients who simply say, I do not want to go to a blood monitoring clinic. Okay, because they've actually been with their husband for the last 10 years and it takes up all their life. But equally, I've had patients say to me, I would like to know if this is working for me. In other words, they would like to have a test every so often to make sure that it is working. So people are different, and that is why patient choice is important. We may have a preference, but I think we've got to discuss that. What will help us is there are also large-scale audit data happening at this moment, which are ongoing for years, what are known as registry data. So all over Europe and America, they are collecting data of atrial fibrillation patients on anticoagulants. And I think the earliest of these will be out in 2016, and I think end of this year there'll be some interim data. And what that shows is, what do real life people, how do they fare taking anticoagulants? Because in a trial, people are monitored much more closely. In real life, you get started on a tablet, you may not be seen for a few months after that. So it's about trying to identify what happens in real life. And that is why I love some of the audits that Shuja brings along, because it's real life. And that is where we need to work on. And again, with the newer anticoagulants, it is important that the clinician who starts them takes the responsibility to ensure that follow-up is happening and the list of things which are checked at every follow-up. And you also mentioned about self-monitoring. And NICE has endorsed it. So I think in this room, if all of you, as you get older, had atrial fibrillation, how many people would like to self-monitor and manage their own? And can you see, this is what happens in real life. The more aware you are, the more educated you are, the more you understand the issues, I think you want to have an active role in self-management. And I think, wouldn't it be wonderful, technology, if you take your smartphone, you have an app that actually tells you what is the date today, what is the INR like, you put that in, and it tells you, continue it for the next 2 weeks. And I think that is what technology does, and I think is you've got to embrace the good side of technology. There are bad sides as well. You will always have the anxious person who checks it every day and then rings the GP up at 6:30 at night and saying, what shall I do? Okay, but hopefully that will be the few patients. So there's a plus and a minus side to everything we do. So what is the action from this? So I think from a population medicine point of view, these are the 3 subgroups that I would want to get on board. First group are the patients who are living out there who have no understanding that they have AF. Now, AF happens in various guises, and I'm sure Som will actually take you through that. But a lot of the times, you do a 24-hour tape, and some people have 15 runs of AF or 10, and then they actually go back to normal. And they are not aware that that is happening. Some people are in AF all the time, and they are not aware that their pulse is irregular. So you've heard about detection strategies, you've heard about technology, and you've heard, I'm glad that Shuja mentioned it, people going into hospitals, lying in a hospital bed, they have their pulse and their BP checked, but electronically, nobody touches their pulse anymore. So it's about trying to make sure that we start to touch people again and feel a pulse. So that is the first group. The second group is what I showed before. So these are the people who have AF, but they are not on an anticoagulant, that's 30 to 40%. And I think, again, we have to develop strategies which allows us to review all of those patients. And I think a fantastic example was given by the Fire and Wild presenter. Sorry, I forgot your first name. Is it Louise? I think it's fantastic. And it's work like that that actually makes these happen. And the third group are people on warfarin, but their warfarin isn't working all the time. So it's about having quality measures for every provider. Every provider who organizes anticoagulation services must, as a mandatory thing, provide data and reports of what proportion are taking their warfarin and what proportion are taking it well. And we should really be making sure that these happen. There should be protocols for dealing with poor warfarin control. So it's quite a lot of work to do. And we are doing good work, but this just carries on. And so my key messages are, if you think AF, you've got to think stroke, and it's about making every patient count. Feel their hand. I don't do it all the time, I'm getting better. And it is just something you've got to keep practicing to make it happen. So what have we done? I've anonymized this. These are the last 3 slides, so don't worry. So as part of the stroke review, the end-to-end review, we have actually set up a list of what should good look like. So what is the best possible way of managing all the different bits within the primary and secondary prevention of atrial fibrillation and stroke. So, and Jeannie and I, we've actually done a bit of traveling around trying to identify what do individual areas do well and trying to give them an amber, a traffic light rating effectively. And I take on the point that we've got to look at stroke as a whole, not just AF. We've got to look at blood pressure, lifestyle, smoking. Everything is important. So hopefully, this ranges across, are the NHS health checks being offered? Are we detecting AF? Mandatory pulse rhythm checks for over 65s? Are we using GRASP or a similar software to look at population statistics? And the next page goes on to, our nursing home staff, are they trained to check basic vital signs? Our social care staff check, they've got so many carers going and looking after elderly people. Do they know how to feel a pulse? Raising patients' awareness of strokes, TIAs, risk factors, availability of information, access to services. So we are looking at a lot of these things, and you can see lots of yellows and reds. So there is all work to be done. Okay. What is AF management, anticoag prescribing? what is the access to these services, how is blood pressure being treated, and if somebody is unfortunate to have a stroke or a TIA, are these patients being reviewed at the right time to make sure that they are making the right changes, and are they being advised to do so? So these are the main areas we are focusing on. So that is actually quite a lot of work yet to happen. The last step, I don't think we can ever stop emphasizing the importance of fabulous media campaigns. The one that you remember, ask anybody, the one that my son immediately said is the cigarette where you start smoking and the middle of the cigarette starts to become like a tumor. People remember things, and it's about pushing this information fast. I think it's a fabulous campaign, and I think health education has to carry on. Thank you.